Welcome, everyone, to Creating a Family. Talk about adoption and infertility. Today, we're going to be talking about a subject that is in the news and is certainly something that many people in our audience are facing, and that is how to survive the first 6 months home with a baby that's been exposed prenatally to opiates. Fascinating topic, important topic. I think you're going to enjoy it. Here's a sample of what you're going to hear.
We also recommend night feedings or sleep feedings, whereas you don't fully wake the infant when you know they're about to wake up for a bottle. You go ahead and give it to them while they're still asleep and try not to wake them so that you can not get them fully aroused.
This show is brought to you by Creating a Family. We are the National Adoption and Infertility Education and Support nonprofit. I'm Dawn Davenport. I'm your host and the director of Creating a Family. You can find out all about us and our resources online at creatingafamily.org. The Creating a Family radio show is underwritten by Jockey Being Family Foundation. They believe that every child deserves to grow up with a loving family in a forever home. You can find out more about their mission at their website. I should add, it's a new website, jockeybeingfamily.com. You can also support their efforts by attending their gala, the Jockey Being Family Gala and Golf Classic. It's going to be May 20th and 21st at the Grand Geneva Resort and Spa near Kenosha, Wisconsin. Some of us are going. It's going to be so much fun. Can't wait. Today we're going to be talking about prenatal exposure, specifically what to expect at the hospital and the first 6 months home. This is a topic that affects fostering families and adopting families. Our guests to talk about this topic are Dr. Evette Horton. She is an assistant professor and director of child clinical services at the UNC Horizons Program in Chapel Hill, North Carolina. She specializes in working with children exposed to prenatal substance use and infant mental health. We also have Danielle Goodman. She is I'm giving you a doctoral degree. Let's call this an honorary degree. Yeah, I know. It's an easy way to get one.
Yes.
Well, you know, Danielle, you've been on the show a number of times, so I think you should deserve an honorary Creating a Family doctor.
Thank you.
Yeah. All title, no pay. Anyway, Danielle Goodman, she is an adoption social worker with Adoptions from the Heart, and she works with families who have adopted children who have been exposed prenatally to opiates. So welcome both Dr. Horton as well as Dr. Goodman, or who else? Otherwise,
yes.
I'll call Danielle.
I wish I had known that before I got mine, that I could get it a little easier.
Well, Dr. Horton, just come on this show enough times, and apparently we'll just give you a...
Okay.
Okay. All right. The topic today is, for this subject, is opiate exposure and how it affects children, infants in specific. How does it affect them at birth, the first weeks after birth, and the first 6 months? Dr. Horton, I want to begin with some just general information, because a lot of the people who are going to be listening to this interview are going to be people who are considering whether to accept a foster placement or an adoption match with a child that has been exposed. So first, just really generally, what type of drugs are included under the category of opiates? What would we know of if we heard that a parent or a birth parent had used a drug? What would we think of as an opiate?
Right. Well, there's a couple different ways that you can get an opiate. You can get it through misuse and addiction. In that case, you might be talking about some of the ones you've been reading about in the news, heroin, pain pills that you are misusing, that you aren't prescribed. There are some folks who are prescribed because of severe pain diagnoses and are on a kind of managed dose of pain meds during the pregnancy. So those are, you might hear some folks talking about Suboxone or Methadone or things like that that are generally safe for pregnancy.
And then there are people who are taking, as you point out, they're under they're not illegal, they are illegal drugs they are taking, and that would be, that includes some of the Oxycontin, some of those. Are they also?
Yeah. Those are the pain, are they considered pain pills, but yes.
Right. They can be abused, but it's possible, and I think more often we see that they're being abused at this for the families that we're talking about. Right.
Yeah.
Okay.
There's been a huge increase, as you stated at the beginning of the show, like a 5-fold increase in the past 15, 20 years of having children born with exposure to opioids.
Exactly. So just generally, I don't want to get into a lot of the details, but just generally, how do opiates used during pregnancy affect the fetus?
And I'm not a medical doctor, but generally you tend to see a lower birth weight in the baby. They are at higher risk for miscarriage, especially if they stop abruptly, which is why we have some of these medical management medicines that we use. They might have neonatal abstinence syndrome if they've been exposed to it. So obviously it's an important issue that we need to really study and understand.
Yeah, absolutely. And how can you tell at birth if a baby has been exposed? Because oftentimes we don't know. The parent, the mom, has not disclosed. So what would be, and Dr. Horton, I'm going to direct this one to you as well, what would be some of the symptoms or the signs that you would look for in a newborn that would indicate that the child, that the baby may have been exposed?
Well, there's changes kind of in their central nervous system. They may have really high-pitched crying. They may be more irritable. Their reflexes that all newborns have may be more exaggerated. They can have tremors, which is just a light shaking of the arms and limbs. You also see increased autonomic nervous system symptoms such as sweating and fever and sneezing. They can often have gastrointestinal distress too. They have trouble feeding, latching on, and very loose stools. That's common. Those are the big ones that I can think of.
Okay. All would be certainly worrisome. And we hear, and you mentioned it earlier, neonatal abstinence syndrome. What is that, and how are those symptoms any different? But first of all, what is it's called NAS, neonatal abstinence syndrome?
NAS is just a withdrawal due to some physical dependence during the pregnancy to the fetus. So it's not an addiction, it's just a withdrawal. And it can come from other medications other than opioids, sometimes nicotine, sometimes SSRIs, which are your antidepressants, can cause this kind of withdrawal. So it's not just opioids, but it is pretty common in opioids to have this withdrawal reaction.
So the NAS means that the child is withdrawing from the drug. So what are the symptoms of withdrawal?
Yeah, and that's very much what I just stated. So what I was just talking about, like what you see in a newborn who has been exposed, those are the symptoms. So there are various rating scales that physicians use to monitor infants once we find out they've been exposed to opioids, or we suspect that they're having some sort of dependence and we're keeping an eye on it, that are checklists for all these different symptoms I just described, like the irritability and the crying and the sneezing and the loose stools and those sort of things. And they get a score, and once the scores get high, then we know that they are in full-on withdrawal and we need to do something to assist the infant.
Danielle, in your experience working with families, and in your case there are families who are adopting children that have been exposed, are there some drugs that cause worse symptoms that you've seen? And then Dr. Horton, I'd like to get you to chime in on this as well.
Not necessarily. And what I tell families that we're working with is sometimes, you had asked a question about like timing in pregnancy before I think we got on the air, and sometimes like a lot of it depends on how the mom herself is metabolizing that drug, whatever drug it is that she's taking, and then in turn how the baby metabolizes it once the baby's here, on whether or not they will withdraw or not. So, amphetamines, barbiturates are also a couple drugs that can cause withdrawal symptoms. We are just seeing such an influx of opioids, so specifically heroin, methadone, Suboxone, or Subutex, as well as those prescription drugs, Percocet, oxycodone. And so those all pretty much have very similar symptoms that you're going to see with these babies. And at the hospital that we generally work at our agency, if a mom comes in who hasn't maybe gotten some prenatal care, the hospital is already going to be on the ready to start looking at those babies and start seeing whether or not they are scoring. So they're going to be checking them out a little bit more frequently to kind of see if there is any signs of loose stools, sneezing, tight muscle tone, all of those kind of things, just to double check, because they don't want to then discharge a baby who then might go home and start withdrawing at a later point. But generally, it can be any and all of those drugs could cause some of those symptoms, and we see them all.
So, go ahead, Dr. Horton.
Yeah, those are really good points, because it's important to understand that some things exacerbate a baby's withdrawal. One of the things that we see here is nicotine. So anytime a mom is smoking and taking illicit substances, the risk for having full-on neonatal abstinence syndrome is higher.
Fascinating. Yeah. And one of the things that we downplay is the impact of smoking during pregnancy, but in fact, from it is a drug, and it does impact fetuses and babies. So that's fascinating. I wasn't aware. Are the symptoms, is it possible for a child to have been exposed prenatally to opiates, but not to show the symptoms of neonatal abstinence syndrome, but to have still been exposed? Dr. Horton?
Absolutely. It very much depends on how much opioid the baby was exposed to, whether or not there was nicotine, whether or not there were other substances like other illegal substances involved. And we have had moms here who are on very low doses of Suboxone and didn't smoke, and their babies did not have full-on neonatal abstinence syndrome. I also think, and I hope we're going to talk about, which is my specialty, is what we can do once the baby's born, even if they have been exposed, to minimize having a withdrawal in a baby.
Yeah, we are absolutely going to be talking about that. In fact, we're going to really kind of focus on that. In fact, that's a good lead-in into let's talk. So thank you, actually. Let's talk about, first of all, I just want to talk about the medical treatment. If your baby is born dependent upon any of the substances, the opiates, that their mother has taken, what, Dr. Horton, are the typical treatments that you're going to see at a hospital for a child who is showing the symptoms of dependency, NAS?
That is a great question, and I'm afraid it's not a uniform answer, because it varies on the hospital and different practices across the nation. We're trying to get better at that, and there's a lot of research going on to figure out what is best. At our hospital at UNC, we have found what is best is having the mother go to their own room with the infant and be monitored in their own room together with breastfeeding if possible, and they are again scored on the Finnegan or one of the other scales that we use. And at UNC we use morphine, very tiny doses of morphine to help that we slowly titrate down till the baby is not having symptoms.
Gotcha. And keep in mind that different hospitals do approach this differently. It is
Exactly.
it does seem like that there should be some best standard practices now. Just we're all facing this. Every state in the union is. So it does feel like, but I think there's progress being made in that direction. All right,
Absolutely.
Danielle, what can parents expect at the hospital when a baby is born dependent or was exposed prenatally? And in specific, what I'm asking is what would foster parents or adoptive parents be expecting? What would the hospital experience typically be like?
So they are generally expected to look at, they're probably going to be there being monitored. The babies are going to be monitored for at least 5 days. That seems to be a fairly common general practice because although some babies are going to start showing symptoms of withdrawal between 24 and 72 hours, some babies don't start showing signs of withdrawal until around closer to 5 days. So we always prepare all of our adoptive families that we're working with that they're going to need to be in the hospital for a little bit of time, about a week or so. But then when they're in there, clearly, these babies are getting monitored and watched. I think that it has kind of gone to a protocol at least the hospital that we're working with to do the tinctures of morphine, or I don't know if that's how you call it, but the morphine to kind of help with the baby's withdrawal. And years ago when we first were seeing a little bit more of babies who are withdrawing, some of these hospitals were allowing families to go home with their babies. But we now preface this with any of our adoptive families that you're going to be looking at staying in that hospital. The baby is going to be in the hospital being managed medically until the baby's withdrawal is completely subsided. And so that could mean, depending on the baby, it could be a week or it could be 6 weeks. I'd say on average what we generally see is about between 2 and 4 weeks of a time, and that's just based on, they have to get the baby stable on that medication first, and then they start weaning the baby off of that morphine medication. So we definitely are prefacing the fact that their initial time period is going to be a lot of hospital stay, for possibly a month or maybe even a little longer.
Dr. Horton, are you seeing babies in your practice being kept for the average of 2 to 4 weeks, or depending, of course, on how stable the baby is and how quickly they can become weaned off of the morphine? What are you seeing, length of stay?
Yeah, and that does vary widely, but I don't know how much your listeners know about our program, but we're a residential substance use treatment program, and so we take moms with substance use disorders and give them high-quality, intensive prenatal care, a place to stay, and treatment for their addiction. And our outcomes are better than most, in that we have less babies with low birth weight. We have shorter stays generally than the 6 weeks. We average, I would say, was about 5 days to 14, so 2 weeks max. And I think a lot of hospitals are still using the NICU to care for these infants, and that sometimes can up the stay because it's kind of overstimulating in there, and we're finding that the rooming in protocol that I described earlier really helps decrease the amount of morphine needed and the length of stay.
And I wanted to bring that up because I know that is I'm not sure it's controversial. I just don't know that many hospitals do it. And in your case, and I think we can rest assured that most of the families who will be listening probably do not have the birth mothers have not had access to the high quality program that you're talking about. So I think that we can assume that probably isn't an option for them, unfortunately. Danielle, Are you seeing a movement in the hospitals that you work with to allow rooming in, and is it being allowed with the adoptive family and or foster family?
Yes. So, a lot of our hospitals are actually going to almost, taking a section of different areas of the hospital and having what is classified as like an NAS wing. So multiple hospitals that we're working with actually have a separate section so that adoptive and foster families can be in there rooming with the baby, because a lot of times what we have found is, if a family is there and is consistently there and is there doing skin to skin, holding the baby, tightly, like up to their chest and holding them and comforting them, they actually do much better. So their scores tend to be a little bit on the lower side. And then again, it might not be as high of a dosage of medication if they end up needing that, or they may be able to go home a little quicker. And so that's something that we definitely promote, and a lot of our hospitals are promoting adoptive families coming and rooming with the babies so that way they can get that care, because God love our nurses and doctors. They do a wonderful job, but they have so many other patients to take care of. They don't have the time allowable to them to care for each individual NAS baby. So having the family members there and caring for these children does make a world of difference.
Danielle, what could an adoptive or even a foster parent, if they know that they are going to be, and this is particularly true in the adoptive situation and can be true in the fostering situation, where they are anticipating the birth of a child who may have NAS but probably has had prenatal exposure, is there something that they could do ahead of time to work with the hospital to make certain that they would be allowed to have a room at the hospital, room in if the hospital will allow it, or if not, what they can do in the NICU to try to replicate some of the benefits, because oftentimes adoptive parents will know in advance and could be proactive. So what are some steps that they can take to be proactive?
I mean, I think definitely when an adoptive or foster family is working with an agency, that's kind of our step in the process, is to kind of connect with that hospital, see what their policies and procedures are with respect to, are they going to allow that family to be in there, to have maybe a separate room. And I do find that, thankfully we do work with a lot of adoption-friendly hospitals who really do look at it as a huge positive thing if a family is going to be able to be in there caring for that baby a little bit more. So we do find that they will, as long as space allows, hopefully try to find those parents with that baby a separate room so that they can provide most, if not all, of the care for those babies. But I don't necessarily think anything other than us as an agency reaching out, because sometimes some of these hospitals, like the doctor said, there's still a lot of NICUs. There's still hospitals in different areas across the country who don't have that allowability for a one-on-one room. I just say the most important thing for an adoptive or foster family is just kind of to know that if you're open to that exposure, know that it's not a quick and easy fix. You're going to really want to prepare yourself, prepare your work, prepare your home life, that you're going to want to be in that hospital caring for that baby as much as possible. If the baby's in the NICU and you might not be able to spend the night there, but try to be there as much as possible, because we have just seen, I don't know if there's necessarily studies that have proven this yet, but just in our experience, those babies who have somebody there caring for them almost around the clock do way better, than so just kind of prepping themselves for knowing that their home life is going to be a little disrupted for, possibly a month of having to be in a separate area, in maybe a different state, in a hospital, caring for this baby is really important for them to realize beforehand.
Yeah, I'm really glad you talked about the preparing go in expecting the worst. And my grandmothers expect the worst, hope for the best, and settle for anything in between.
That's right.
Yeah, so you can and to anticipate that in advance and get your life structured, because that is one of the advantages to adoption, is that you do have time in advance to be planning for this. You are listening to an interview with Creating a Family. We primarily keep in touch with our community through our weekly e-newsletter. We would love for you to sign up. We have an adoption fostering one, and it comes out weekly. It has resources that I think you will find very valuable. You can sign up. It's free. You can sign up on any page of our website, creatingafamily.org. It's on the top right of the website. Dr. Horton, we received a question from Bethany, and her question was, can the seizures caused by the drugs in pregnancy cause brain damage? You did not mention, or maybe I didn't capture it. Are seizures a side effect of prenatal exposure, or can they be?
They more than likely can be if you don't catch neonatal abstinence syndrome quickly, but I have not heard of that, and I haven't had any infants in my clinical work that have had that happen.
So the treatment that we use, which is the titrate of morphine that's being titrated down, is to prevent symptoms such as that, the more severe symptoms. Am I understanding you correctly?
Yes.
Okay.
And that's one of the reasons it's in substance use treatment with pregnant women that we use more controlled opioid during pregnancy, because if you do have a substance use disorder and you stopped abruptly, you are at higher risk for miscarriage, and I did say that. So we slowly put them on a more controlled medication. There are varieties of those kind of medications. We use Suboxone here, and that really keeps the baby more steady and again is part of our good outcomes in terms of increasing birth weight, lower length of stay in the hospital, and things like that. I wanted to add, if it's okay, to what Danielle said, because she said it great. There is research showing that rooming in, regardless if it's the mother or the foster mother or anybody that can be in there and room in and hold that baby, does decrease the need for medication for the infant, the length of the medication and the length of the stay in the hospital.
I have read that too, and the length of stay is what they specifically say, as well as the length of time and the amount of the medication that the baby will need.
Exactly.
Which is excellent for children and for parents, and quite frankly for hospitals as well. All right. So Danielle, we've talked about that. At this point, we've had the baby has been in the hospital, and the parents will may or may not be allowed to room in. That is, as we've discussed, something that, if possible, has good outcomes and preferred outcomes. So that is something. Are there other specific things that you mentioned that are important? You mentioned skin to skin. So tell us about that, and then and for how long is it recommended that you emphasize skin to skin contact with the baby?
I mean, I think definitely that we have seen a trend more recently from hospitals wanting that regardless of if the baby is born with possible addiction issues or not. I can tell you that we're also one of the states that we're licensed in is Connecticut, and they have their hospitals there, I think it's Yale that's up in that area, have done some studies about how important skin to skin is. So, we preface that with our families, adoptive families, and we're a non-discriminatory agency. So even if there happen to be a male couple, be prepared to take your shirt off and don some skin to skin. At that particular hospital, wants it to be done as much as possible. So literally, caring for the baby and having the baby on your chest and that warmth is really, really important and vital to just help them feel comforted. So I'd say that, I don't know if there's 100%, answer to that, but I think that the more that families can be willing to do the skin-to-skin, the better.
Okay, excellent. So in the hospital, tips for parents who are going to be parenting a baby who's been prenatally exposed. So rooming in when possible, skin-to-skin contact when possible. Dr. Horton, other things that right now I'm focusing on the hospital time, other things that you would recommend for parents who will be bringing home, hopefully in a shorter period of time, a baby who is prenatally exposed to opiates.
Right, and kangaroo care, which is, another way to say skin-to-skin, has been shown to really help these babies. It really helps all babies. Right? So all newborns really benefit from that. But because these babies' central nervous systems are kind of stressed, they benefit from it even more. So the skin-to-skin, decreasing the environmental stimuli, turning down the lights, keeping it low, almost like they're still in the womb so they can have time. Another reason why that kangaroo therapy works so well is they can hear your heart, which is exactly what they did inside the womb, and so that's very calming. So keeping the lights down low, doing small on-demand feedings are very helpful. Using pacifiers, sometimes people don't want to use pacifiers because they're worried about consequences for later, but these babies, because they're a little bit stressed, have a very strong sucking reflex, and so using a pacifier does help soothe them. Swaddling is really important too. They really, again, swaddling sort of, when you wrap up the baby and kind of calm the legs and the arms, really helps soothe the baby, much like, again, you're recreating that environment in the womb. Those are all great things for newborns, those first few weeks.
Excellent. And what about the use of rocking? If you're not able to be, when you're not doing kangaroo care or the skin-to-skin or carrying the baby on you, what about, we often will see them in a rocking, in some type of rocker. Is that helpful, or is it from a soothing standpoint, or is it done or is it being done? Maybe I should ask.
We definitely see that often in our hospitals. A lot of times they actually have donated swings or the gliders, as they're called, and it does seem to generally calm down the babies. Probably, again, because it still is kind of replicating the womb with the, if a woman is walking and she's pregnant, the baby inside is kind of rocking back and forth. So I think it does help.
Absolutely.
Okay. Excellent. Very good. All right. Now, the baby, how is the decision made, Dr. Horton, for when the baby is ready to go home? At this point, everybody is ready and anxious to get out of the hospital. They've been there anywhere from 2 to 4 to 6 weeks, depending on any number of factors, and everyone's anxious to get home. So what are the deciding factors? Let's assume in this case that one of them is not whether the home environment is going to be stable, because I realize that often these children are going home with birth families, and so there's some different issues. In this case, let's make the assumption that the child will be going home with an adoptive family or a foster family. So, Dr. Horton, what are the factors that the hospital is looking at for making a decision on whether the baby can go home?
Right. So I don't know the exact protocol, but my understanding is that, and it's going to, of course, vary by hospital, but once the child has been titrated off the morphine or whatever medication they're using at that hospital, and they've seen that the child is scoring on these assessments below clinical range, they'll keep an eye on it, and once they see that, then the baby can go home generally. Okay, so once and Danielle, are you seeing anything different in your experience off of morphine and scoring well?
Right. So normally they are generally looking at, they have to be off the morphine, and they generally give them a 24 to 48 hour period where they're still checking their scores, and if they are low enough, then at that point, they do prepare them for discharge. So I see pretty much the same thing.
Okay. So now the child and the family, the baby and the family are going home. Danielle, what do you tell people to expect, let's say the first couple of weeks that the baby has been brought home?
I mean, generally what doctors will still say is that there may still be, their NAS scores may not be still 0, so you may still see some tight muscle tone, some crying. They may still go home and have loose stools. So it's still things that most of our families, we tell them to get familiar with that score check sheet so that way they kind of know what to be on the lookout for. It definitely does subside within the first, few weeks to a month of them being home generally. But there are still some things that, they want to get good quality diaper rash cream and make sure that they're still, having a safe and calm environment, when they bring that baby home. But generally, what we see is those babies, even within the first couple of weeks of coming home, do really well, and they don't have nearly to the extent of any of the issues or side effects associated with the withdrawal once they've come home, because they've already gone through all of that. A lot of times our hospitals will call in a referral to like a child watch program just to have somebody come out there and do an assessment on the babies, especially for that muscle tone. Make sure that, the parents are exercising those muscles, and so for the reflexes and that sort of thing, because the muscles were so tight for a while, and so that has, shown to be a good step as well.
And does that usually have to be something that the parent can't call on their own, that they need to ask their doctor to arrange admittance to one of the child watch programs, Danielle?
I mean, generally, a lot of times the hospital is doing that referral initially, but I don't think, and I'm not 100% sure, but I think that the parents, if they go home from a particular hospital that might not have made the referral and that family feels like that might be a good step for their child, they can make that referral call as well.
Well, sometimes in an adoptive situation, the child is in a different even state, or certainly not in the same location. Now, fostering, that usually isn't the case. So with fostering, it isn't. Let's go back and ask. In fact, Danielle, I'll ask you this: is it helpful to take some preemptive bottom care for preventing diaper rash, because we've got a situation where we know oftentimes we've got loose stools. So what do you encourage families to do to take care of those little bottoms ahead of time before we develop a rash?
Right. Sometimes those hospitals actually will do that if they know that the baby might even, have had the exposure or might even start to be scoring pretty quickly. A lot of times those hospitals are providing that diaper rash cream beforehand, and basically they're telling the families to make sure that they get it clean and try to pat it dry, and then put that cream on with every single diaper change, regardless of if it was a bowel movement diaper change or not, just to kind of make sure that they're, precautionarily keeping that bottom, healthy.
Right. Yeah, exactly. Before, because we know that the baby is likely going to be at higher risk, and once a rash develops, then you've got significant discomfort, and you're fighting to get it cleared up. So sometimes treating it in advance, will prevent that from happening. Dr. Horton, what challenges, additional challenges, do you see parents face when they are first home with a baby with NAS or prenatal exposure?
Can I add something before I do that? One of the things we didn't mention, and I know that this is really important because there are a lot of studies showing that breastfeeding is associated with reduced severity of withdrawal. And so I know that not all the families listening have that option. But if they do have that option, that really helps the baby during those first few days. So I just wanted to add that. But what we also see is exactly like Danielle said, depending on whatever assessment they're using, you usually will go home and there still will be some excessive irritability, increased crying. Sometimes they have slightly disorganized suck, so their feeding is difficult at times. And so those are some of the things you might see that we in our program go in and assist the mother with, to kind of show them and figure out what works best for this baby. Another thing that
go ahead. No,
the other thing that Danielle mentioned is infant massage, and if the baby will tolerate it, because Danielle was talking about those muscles that are stiff from the tremors and stretching out. Infant massage has been really helpful for a lot of our babies.
Yeah, both from the soothing standpoint as well as the muscle relaxation standpoint, both of which are important. And I was glad you raised that about breastfeeding. It's in the environment we're talking about. It's more complicated because at this point it's not up to the adoptive mom to necessarily be able to to make that decision. But what I hear you saying is that if the birth mom is willing, and not all are, but if she is willing, sometimes that it takes some preemptive work from with adoptive parents as well as foster parents to be encouraging of it as opposed to discouraging. So I think it's still a valid thing to raise. I wanted to come back to the difficulty in feeding because I think that is something that we certainly hear from parents. Let's talk about, you mentioned a disorganized sucking. I think that's pretty self-explanatory. But can you explain a little more about what that is, and then specifically what parents can do? And in this case, most of them will likely be bottle feeding.
Right.
So what parents can do to try to help with the potential feeding issues?
Right, so it's going to require some patience, at least for a little while. I agree with what Danielle said. Largely, once they're home, things get back to normal really quickly. But you may have a child who, doesn't have a good grasp on the bottle and is leaking from the side, and so you have to really look at their latch onto the bottle. They may fatigue easily, so they can suck for a while, but they stop, and sometimes the parents may be wondering, they're only eating this amount, but they're eating more frequently just because they kind of are getting used to that sucking and feeling better about eating now that they're home from the hospital. So usually a little bit of work. We go in and we look at the latch onto the bottle. We watch them eat. We make sure that their lips are correctly positioned on the bottle and as they would be on a breast, either way, and kind of help the mom know what those cues are to help their baby get through a feeding.
Is there any particular bottle that you recommend that is easier for a baby to latch onto, one that is not latching on well?
We use, I think it's Dr. Brown's frequently because it's supposed to reduce the gas that a lot of babies get, and that seemed to have been helpful for a lot of our moms. But they have so many new ones out, I can't even keep up. So some of our babies who are doing some breastfeeding and then some bottle feeding prefer the ones that are shaped more like a breast. So you may have to try several different types to find what works best for your baby.
Yeah, so the I think bottom line is if you are noticing milk coming out from when the baby is sucking, or the baby fatiguing quickly, not getting a full, start experimenting with different nipples in particular, and buy a couple and try them and see which one is easier, and it's a good.
Sometimes it's not just the bottles themselves; it's the nipples, because
the nipple. Yeah,
depending if the baby was a preemie, they have nipples these days are generally labeled. whether they're a premature nipple versus like a one, which is a newborn full-term infant. And so looking and trying out different sizes of the nipple holes that best fit for that baby at that time. So it's kind of a moving target a lot of times. But usually within a few days we can kind of figure out what works best for that baby at that moment. And, of course, as all babies grow and change, you might have to change that in a little while.
Yeah, exactly. Now, Dr. Horton, you mentioned that the symptoms, the things get to normal relatively quickly. Let's define that. I mean, what do you mean by relatively quickly? How long should we expect to see the symptoms that we discussed of exposure in a baby? If you can just give us a range that's fairly typical.
Typically, they're mostly resolved by 3 months is what we see. You might see an occasional tremor or a sneeze, but all newborns sneeze. So, it gets hard to figure out, well, is this from being exposed to it, or is this sort of a normal thing that all babies do? So usually by 3 months. Sometimes I find that when they go home that first month or two, they need, similar to what they're getting in the hospital, they need the skin-to-skin, they need swaddling, they need a calm, quiet environment with the lights low, and more frequent feedings during those first couple of months. But if you walked into our child care and looked at our infants, you would not be able to tell, for the most part, which baby had which exposure, because usually a lot of that is resolved.
Danielle, the most important issue all new parents face is sleep, or lack thereof. What type of sleep issues are common with babies who have been exposed prenatally? Oops, I think we may have, hang on just a second. Danielle, I apologize. Let me try this again. If you could talk to us about sleep issues that are fairly common with babies who were exposed prenatally to opiates.
I think that what we generally see, and this might not just be a prenatally exposed baby, but, initially most newborns have their days and their nights confused, which hence, causes that lack of sleep for new parents, regardless of if it's a biological parent or an adoptive or foster parent. And I think that, for as much as families can do, they need to have a plan in place. And, if there is a two-parent household, I think what we see works really, really well is them sharing the load. So one parent, takes part of the night and the other parent takes the other half of the night, just so that one can get a good chunk of sleep at a time. Doesn't work so well if somebody happens to be a single parent. I think, you just have to preface the fact that most babies, again, whether or not they're showing any signs of withdrawal or not, sometimes have their days and their nights confused. So, and they need to eat every 2 to 3 hours. So, you're going to expect that you're not going to get a full 8 hours of sleep any longer once you become a parent. You need to kind of, prep yourself for the lack of sleep. But I do think that there can be a little bit more irritability. So, unlike a regular newborn who might get that bottle, their belly is filled, they go right back to sleep. A baby that has had some withdrawal might be irritable, might need that skin-to-skin. They might need you to stay up longer with them in the interim. And we always tell our families that when the baby's sleeping, you try to get some rest, because we realize that, you still need to do laundry and vacuum and that sort of thing, but sleep is really important, and you're not going to function if you're not sleeping. So even if it's during the day, when they go down for some sleep, you may want to go down for some sleep as well.
And Dr. Horton, I'm agreeing with you. I'm shaking my head, Danielle, as if that would be helpful for you. I've been doing this for over 10 years. You would think I would know. Dr. Horton, we certainly, and I don't know if this is anecdotal, but do you also, we hear from people that when they come home that it's helpful to be prepared for a longer period of sleep issues if the baby has been prenatally exposed. Now, this could also just be because they've been in the hospital or could be for any number of reasons, or the increased irritability or the more frequent feedings. Do you also see that there's a little longer sleep disruption before the baby gets into a good pattern with babies who are prenatally exposed?
Sometimes yes, not all the time, but sometimes yes. It depends somewhat on the severity of the NAS. And we find that the swaddling and all the things you were doing in the hospital really help with that. The other couple of things that I want to add to what Danielle said is having the babies get some daylight during the day, not obviously
good one. Yeah, that's
daylight
a great one.
like as in you're going to get sunburn, that's not healthy, but just being near a window during the day to help keep their nights from switching. We also recommend night feedings or sleep feedings, whereas you don't fully wake the infant when you know they're about to wake up for a bottle. You go ahead and give it to them while they're still asleep and try not to wake them so that you can not get them fully aroused. We really teach to notice the signs of the different types of sleep in infants, the difference between active sleep and deep sleep, and we try and catch them when they're in that active phase, moving around a little bit but not quite awake, and give them a sleep feeding, a little bottle then, and that kind of helps keep them calm through the next sleep cycle, and hopefully you'll be able to get some sleep too.
Yeah, that's interesting. I could see that would be useful because, and then also keeps the baby from getting in the habit of waking up to be fed. They're being fed, but they're not having to be encouraged back to sleep since they never fully wake. That makes very good sense.
Now, obviously, you can't do that all the time if the baby's had a diaper or something, right? But if you can, it does help keep them calm and keep them in a sleep cycle longer. Yeah.
Okay. Excellent. The next question, we have a question, and I'm going to direct this to you, Danielle. This is from Louisa. She said, "We are fostering a baby that was born addicted to heroin. It is not clear whether he will become available for adoption or will be reunited. His mom was in rehab but dropped out last week. I am really struggling with bad feelings towards her. Every time I see how this little boy is suffering, I get so angry. I know I am supposed to be working with her and helping her reunite. I also know that if we are able to adopt this baby, that I need not to hate her or be angry with her, but I am really struggling. How can I not blame her for what she did to this innocent baby?" I think this is a feeling that is a lot of adoptive and foster families have. They see the baby suffering, and it's hard not to feel negatively towards the birth mom, even if you believe that's not in the child's best interest to have these feelings. Danielle, can you give some advice to Louisa, who's struggling with this right now?
Yeah, I mean, I think that it's just important to remember that, the child that she's fostering's birth mom was in a circumstance, and addiction crosses all races, all socioeconomic statuses. I mean, everybody. I mean, this epidemic is humongous now, and heroin specifically is hugely addictive. And, I think sometimes for families who just want to be parents so bad, they forget that part that this woman who gave birth is in a completely different circumstance than they are in. So hopefully for this child, she will kind of, even if she still continues to have those feelings, not let them, come forth and, cause a negative reaction to the birth mom, because some things, unfortunately, are out of their control. And, I truly still don't believe that even when a woman gets pregnant, she may or may not have known that she was pregnant for a while. I think that women try to do the best that they can do, and they, it sounds like she was trying to better herself, but, that pull for that addiction is really, really hard, sometimes, and, but there's still love. She chose to continue on with her pregnancy, which she may or may not have had to do, and so she wanted to be able to give her child life, and and for that I think that this foster family should at least be respectful of that piece of it, that here's this beautiful child that she's caring for, and even though he's had a rough start to life, hopefully whatever is meant to happen for his best interest will happen, But remember that in adoption or in foster, we can't make those decisions for those men and women, that they're making them themselves. And sometimes it's really hard. That's why I think the epidemic is as huge as it is right now. I mean, it's a crisis.
Can I add something to that?
Yes, please.
I think those feelings are really common. They're really common even in the moms that we have here. They have enormous guilt. But one thing that is really helpful is to realize that addiction is a disease. And so instead of being mad at the mother, be mad at the disease. This is a horrible disease that mothers don't want to do this to their babies, but their addiction takes over their brain, literally. And, you know, it kind of helps to not frame it as a mother, as the disease instead.
Yeah, I like that. And I also take the intent out of it. So often our anger is focused on the mother did this to the child, which implies intent, when in fact I would almost guarantee that there is no mother who intentionally set out to harm her child, which is just another way of saying it. It's the focus your anger on the addiction, on the disease, because it wasn't the intent to harm. And that leads into a question that I wanted to direct to you, Dr. Horton, and this is she asked me to call her Gamma. She said, I am raising my 1-year-old granddaughter who is born dependent on drugs that her mother, my daughter, took during pregnancy. My daughter is trying to get clean, but she is currently using. We hope to get her back into rehab soon. She is so filled with regret that I think it is interfering with her recovery. How can I help her? At first, she didn't even want to be around her daughter because of the guilt. As the daughter, as the baby. As C has gotten older, she is doing better. She is now coming around more, but she is still racked with guilt. So this is a woman who is raising her granddaughter, and she's also trying to help her daughter, who is, as you mentioned, racked with guilt. Dr. Horton, can you give any advice to this woman?
This is so common. This is absolutely so common. Exactly what you said before. No mother really wants to do harm to her baby, but when the disease takes over. And I think that message that I just said is helpful for the mothers, too. They need to not blame themselves. They need to blame their disease and take the next right step, getting into their treatment programs, getting a sponsor, doing all the things that we know work for addiction. One other thing that's really important to know is with the women that we see here is, I liked what Danielle said about their circumstances. Women who get into addiction often have been exposed to many different traumas, and their addiction started as a way to cope with those traumas and then got out of control. So getting treatment for the mom, including counseling, and the whole family can really help with that.
Yeah, absolutely. There's that research that talks about the long-term impact of every single exposure to trauma someone has had, and it's real, and it has a dramatic effect on us, and trauma has a dramatic effect on us and our health. And traumas that these moms have experienced has often led to their use of drugs before, and then ultimately their addiction. All right, so for families that are now raising children who have been prenatally exposed to opiates, what services are typically available? Now, we can't speak, obviously our audience is, the people who are listening to this interview are national, so we can't speak to specific programs in one or two locations. But what type of general services do parents need to be thinking about contacting? We already talked, I believe, Danielle, you raised the Child Watch programs, so that's available for 0 to 3 oftentimes. What are some other programs at different ages that parents need to become aware of if in case they feel like their child would benefit? Danielle?
I mean, I think that they just need to be aware that, and again, we're talking more about immediate, but longer term, like if they need
No, I'm
to have
talking
any kind
longer
of
term now.
services.
Yeah, longer term now, just so they can become aware of them now. Go ahead.
Right. So, if the child ends up having any kind of issues associated with like some slight learning disabilities, maybe getting some resources in place about some assistance with schoolwork or that sort of thing, because that could be something that we could look at long term, that they may need a little bit more help reading or focus on, other schoolwork type of things. Sometimes, in adoption specifically, adoptees struggle a little bit, with their story and with their situation, regardless of if their birth parents chose adoption, because of, a drug history or not. So looking for some resources for maybe some support groups for adoptees or adoption in general might be a positive thing for families to look into as well.
Okay, excellent. Dr. Horton, what type of services have you seen that are available? I think 0 to 3 type of programs are available most places. Anything other than 0 to 3, or what about from school type of programs that you may want to look for early kindergarten or things like that?
Right. Well, I do think all children, regardless of what they're exposed to, should be monitored for their developmental milestones, including their social and emotional milestones, because a lot of things can happen to kids that can impact them emotionally. So we definitely do weekly home visiting to monitor all of the milestones, including the social and emotional, really helping foster a strong attachment with the primary caregiver, whether that's a foster mother, a grandmother, or the biological mother, and because that has also been shown to be really helpful longitudinally for children, is to having that secure bond. And sometimes these babies, because they're more irritable and fussy, sometimes they are at risk for not having a healthy and secure bond with a primary caregiver. So we want to really ensure that. And so we do the weekly home visiting. There are infant mental health programs in most states. They can be sometimes hard to find, but providers who specialize in working with children from birth to 3 really can be helpful in reducing the stress to the parent, reducing the stress to the infant, and helping form that secure bond.
Excellent. And then as your child does age, contact your local school system and find out what type of programs they have that your child may be eligible. And there's a whole host of them. Some are, focused on the 4 to 5. Some are, a pre-kindergarten. There's just a number of services that school systems may offer that your child may or may not qualify for. But it doesn't hurt to go ahead and learn about them and ahead of time, so that you can access them relatively quickly and find out what it takes to access them. So you could be laying the groundwork, and if you need to be working with your pediatrician or whatever. Well, thank you so very much. I certainly appreciate both Danielle Goodman as well as Dr. Evette Horton for talking with us today about this really important subject, and a subject that is affecting more and more people, more and more families, especially adoptive and foster families. I wanted to remind you that this show, as well as all the resources provided by Creating a Family, could not and would not happen without the generous support of our partners who believe in our mission of providing unbiased information and support to those who are struggling to create a family. Some of our great sponsors include Adoptions from the Heart. They have helped build over 6,000 families since 1985 through domestic infant adoption. They work with people all across the United States and are licensed in Pennsylvania, New Jersey, New York, Delaware, Virginia, and Connecticut. We also have Spence Chapin. They are a licensed and accredited nonprofit organization in the New York City metro area that has been offering adoption services for more than 100 years. Their robust post-adoption support provides birth parents, adoptive parents, and adoptees a supportive community. And we thank them as well as all of our other partners for their support. Now, I know that many of you will be interested in getting more information about the UNC Horizons program that Dr. Horton is affiliated with, as well as Adoptions from the Heart, which is where Danielle Goodman is affiliated. Information can be gotten on Dr. Horton and the Horizons program at their website, UNC Horizons, HORIZONS.org, and you can get more information about Danielle and about Adoptions from the Heart at their website, and that is AFTH, which stands for AdoptionsFromTheHeart.org, AFTH.org. Thank you so much for joining us. I will see you next week.
Right now at the Home Depot, you'll save up to 35% off appliance special buys, like a GE Appliances top-load washer and dryer pair, with deep clean and deep rinse options, a reliable heavy-duty agitator, and 4 precise water levels, just $4.78 each. Wash, dry, save, repeat. Today is the day for doing, with Spring Black Friday savings now at the Home Depot. More saving, more doing. U.S. only while supplies last. Gas dryer extra. See store for details. Valid through April 17th.
Your hands were made for greatness. Mighty hands for painting, paneling, and clicking the submit order button on HomeDepot.com to get that duvet. And these Egyptian cotton towels delivered right to your door. Do more with decor at the Home Depot. Save up to 30% on select bedding and bath. Now at HomeDepot.com. More saving, more kinds of doing. Valid on select items online only. Free delivery on select items $45 or more. Enter promo code BEDBATH15 at purchase for an extra 15% off. Visit HomeDepot.com for more information.